Hello guys, this is Dr. Asif, one of the surgical candidates, and also an examinee of MCPS and FCPS finally. Today we will discuss about a long case which is called the obstructive jaundice due to choledocholithosis, and also head of the pancreas, so carcinoma head of the pancreas. So both cases will give you the existing theory or information about hepatobiliary system related jaundice. Okay, so it is called the obstructive jaundice, which is also called surgical jaundice, which is also called jaundice due to the mechanical cause. Okay, so let's start. So as you can see, this is a very large and clumsy presentation, but first you have to rapport with your patients, and also you have to explain the salient feature. Okay, because it depends of 50 to 60% chances to become pass in the long case. That is how you give output about your case discussions. Okay, so my patient, Mr. X, or he could be he or she, that is 40 years old, service holder, normotensive, non-diabetic, hailing from Bhakara Faridpur, presented with the complaints of recurrent pain in the right upper abdomen for 2 years, as it is a choledocholithosis, so that means there should be a complaint about pain. Okay, so recurrent pain in right upper abdomen for 2 years, yellow discoloration of the skin, sclera and mucous membrane for 3 months, itching all over the body, pale stool and high colored urine for 3 months. Okay, and according to the patient's statement, his presenting complaint started 2 years back. Then he developed recurrent pain in the right hypochondriac region for 2 years, which is colic in nature and moderate in intensity, radiates to the back in the of the right side of the chest and the right shoulder joint, aggravated by taking fatty meals and relieved by taking some medications, name of which he could not mention. Okay, for the last 3 months, patient has consulted constant dull aching pain in the right hypochondriac region. Patient complains of jaundice, which is an episode of cholangitis 3 months back, and the jaundice is intermittent in nature. Patient also complains of itching all over the body and passing clay colored stool and high colored urine for last 3 months. His bladder habit is normal. He has no features of metastasis. He has no significant past history, and he is a non-smoker, non-alcoholic, non-metal nut chewer. He is immunized according to DPI schedule, and he has no history of allergy to any drugs or foods. Patient is ill-looking, cooperative, non-anemic, non-dehydrated. All other vitals are within normal limit. On abdominal examination, shape of the abdomen is normal. Scratch mark all over the abdomen. Flanks are not full. Okay, umbilicus is centrally placed, inverted. No ingress vein, so no visible peristalsis. Hernial orifice are intact. So liver, gallbladder, spleen are not palpable, and the kidneys are not ballotable, or no ascites. Upper border of the liver ductus is present in the fifth intercostal space on the mid clavicular line, and bowel sound is present, and digital rectal examination and other systemic examination reveals no abnormality. Okay, this is a pattern of how you explain your case in front of your teacher, and it should be loud and clear. Okay, so now the questions: what are the possibilities? So maybe benign biliary stricture, or maybe biliary ascariasis, or periampullary carcinoma. Okay, why it is a case of obstructive jaundice? I already said the primary diagnosis should be choledocholithosis or stone in the bile duct, and the other possibilities may be these. Okay, benign biliary stricture, biliary ascariasis, and periampullary carcinoma. Okay, so why it is the case of obstructive jaundice? Okay, that's some yellow coloration of the skin and eye, itching all over the body, pale coloration of the stool, and high colored urine. So these are the points I mentioned in the presentations. And scratch mark all over the body, that means a patient has itching. Which, why it is not a case of carcinoma head of the pancreas? Why it is benign? It could be possibility, but the patient presents the painful. I have told you this is the case of choledocholithosis, so there may be a pain. It is not malignant, and patient has no any points of metastasis as well. So presence with painful intermittent type of obstructive jaundice, whereas in periampullary carcinoma, patient may present with a fluctuating type of jaundice. Why itching occurs in obstructive jaundice? Bile salt deposition in subcutaneous tissue causes irritation of nerve ending and breakdown of mast cell and release of histamine, which releasing itching. Okay, so the main causes of irritation of the nerve by bile salt. So now I will try to explain the three type of jaundice, which is very necessary for understanding. During your question answer sessions, you have to clarify. Okay, so progressive jaundice, the jaundice increases progressively. That means the strongly it will keep rising, that never decreases and never touches the baseline. Causes why? Because of the carcinoma here of the pancreas, which is constantly give pressure to the CBD. That's why there will be no intermittency, or patient may got jaundice continuously. Another one is cholangiocarcinoma, then advanced carcinoma gallbladder. Okay, in case of fluctuating jaundice, that means jaundice fluctuates, that means yellowish discoloration of the coloration increases and decreases but never touches the baseline. Causes choledocholithiasis, choledochal cyst and periampullary carcinoma. Why? Choledocholithiasis, that means the stone in the bile duct. So stone has some space laterally in its sides. That's why the bile should pass through the CBD, not completely obstruct the lumen. Okay, and choledochal cyst is also a pre-malignant condition, sometimes happen in the CBD. And periampullary carcinoma, that means malignancy in the wall of the CBD. It is a very extensive high-grade tumor and prognosis is very bad. So sometimes fluctuating jaundice can be happen. So jaundice and a gap period of healthy period, then another time of jaundice. Okay, and the intermittent jaundice appears, then disappears completely, and if in case of fluctuating, that means increase and decrease, not completely jaundice free. But in case of intermittent, jaundice appears, then disappears completely after a period of time, then again reappears. Okay, so like choledocholithiasis or biliary ascariasis, choledochal cyst and benign stricture. So in this case intermittent jaundice can be happened. Now what are the causes of obstructive jaundice with palpable gallbladder? Okay, these are the question. Like carcinoma head of the pancreas, in this case obstructive jaundice, and also you will palpate gallbladder because you can during palpation of abdomen or right hypochondrian will feel the fundus of the gallbladder. Okay, advanced carcinoma of the gallbladder, that means GB mass. Periampullary carcinoma, double impaction of the stone. Cholangiocarcinoma involving the lower end. Okay, now is it possible to occur progressive type of obstructive jaundice in the stone disease? Is there any possibilities? Yes, it is possible in case of impaction of the stone in lower end of the common bile duct. If stone impact in the lower end, progressive type of obstructive jaundice with palpable gallbladder is possible in double impaction of stone. One in cystic duct, another one is lower end of the common bile duct. So double stone. Okay. Now what investigations will you suggest in this patient? Now another question, what are the series of investigations? So I already mentioned in my other videos that some tests we perform to make diagnosis of the patient. Some tests will go for fitness, for anesthesia. Some investigation will do for routine test as normal health conditions, to know normal health conditions, other patient is fit for any surgery or nutritional imbalance, and some for to prevent anesthetic hazards. Okay, so CBC to see hemoglobin percentage, total count of WBC may increases because of pancreatitis, sometimes due to cholangitis. Okay, the liver function test, LFT, SGPT, SGOT, and alkaline phosphatase. that all composed of liver function test, LFT. Serum bilirubin, total or direct or indirect. Direct bilirubin increase in obstructive jaundice, and HGPT and increased hepatocellular jaundice also increased in the long-standing obstructive jaundice. That means liver will be impaired. That's why HGPT will be raised. And alkaline phosphatase is increased obstructive jaundice. It is because alkaline phosphatase, which is formed from hepatocytes. Okay, during obstructive jaundice, this alkaline phosphatase cannot come through the bile duct to the gut, but it goes backward to the hepatocyte and become accumulated and then transferred to the blood, and that's why alkaline phosphatase is raised. But sometimes alkaline phosphatase can be formed from other organ like prostate. In case of high grade prostatic carcinoma, alkaline phosphatase can be raised in that case. USG of whole abdomen with special attention of hepatobiliary system, that means condition of the liver, echo texture of liver, and a condition of intrahepatic and extrahepatic biliary tree, and surrounding lymph node, and any lump, it could be possibly here. So by ultrasound, but that means ultrasonograph of the hepatobiliary system and pancreas, we can see the liver, extra or intra hepatic biliary tree, and surrounding lymph node and the lump also. Now if USG shows choledocholithosis, that means during ultrasonography you found stone in the CBD and otherwise no more findings, what will you do in that case? So after thorough evaluation and proper counseling of the patient, I will prepare the patient for surgery. That means it is the first answer. Okay, so I will counsel the patients and I will prepare the patient for surgery, and I will discuss the patient party with the cost and outcome of the patient treatment protocol. Okay, then stone, first option is stone extraction by ERCP if ERCP facilities is available in the hospital, and the laparoscopic cholecystectomy with exploration of the common bile duct and extraction of the stone. Yeah, it is an advanced process, but nowadays in our country, but not in our country also, but also all of the world, the hepatobiliary surgeons are going to establish and they are practicing this procedure nowadays very commonly. Okay, and the supraduodenal choledocholithotomy with cholecystectomy, that is a conventional methods, and every general surgeons and as well as the common hepatobiliary surgeons do it randomly. Okay, so what are the selection criteria of the patients for ERCP stone extractions? So which patients we are selecting nowadays for ERCP? Poor risk patient, that means the patient with cardiac disease, the patient with high diabetes or hypertension, or very fat patient, fatty obese patient. In that case, patient with cholangitis, that means the patient has a pre-existing infection, patient with severe pancreatitis, so we cannot operation in that case perform. In that case we have gone through some alternate procedure like ERCP. Some patients with failed laparoscopic stone extraction as an alternative to conversion, retained or recurrent stones after cholecystectomy. After cholecystectomy you found a stone in the CBD, in that case you can't go for another surgery because it will it gives much more stress and the patient might go through the ventilation sometimes. That's why we will go for retained stone retraction by ERCP. Now what will you do in patients with a ductal calculi discovered by intraoperative cholangiography during elective cholecystectomy? So as they usually small floating calculi without dilatations of common bile duct, as these patients have no obstruction and normal liver function test, some surgeons have advocated no interventions other than cholecystectomy. On the ground, these calculi will pass spontaneously. Yes, if the symptoms or complications arise after surgery, endoscopic sphincterotomy can be performed. And other groups prefer appropriate management of these patients is removal either at the time of laparoscopic cholecystectomy by laparoscopic exploration or by post-operative endoscopic sphincterotomy by or ERCP. Now cholecystectomy with supraduodenal choledocholithotomy have been done, and the post-operative T-tube cholangiography has shown a residual stone in CBD. And what we will do? That means after operation you will see there is a stone present in the CBD, and it has been missed or formed after the surgery. Then what we will do? So urgent intervention is not indicated here. If the liver biochemistry is normal, the patient is asymptomatic, and the T-tube cholangiogram shows no organic disease or significant dilatations. There is no dilatations, and the spontaneous passage is likely if the calculi are small and less than 3 millimeter, and maybe aided by simple measures like T-tube clamping. Okay, if the patient is tolerates clamping and provides no unwanted symptoms or complications develop, such as conservative approach can be continued for a few weeks. That means you don't need to go for surgery, because if the small stone is small, less than 3 millimeter, then during T-tube clamping the force of bile can push the stone to the gut. It is an option, it may be a hypothesis, it sometimes worked, but if there is no any symptoms or dilatations, in that case you will continue the conservative management or keep watch and observation for 2 weeks, few weeks, and then if the situation reviewed radiologically, that means by X-ray or T-tube cholangiogram, you can do again this. If the above measures fail, then various methods available like non-surgical management. What are those? Like flushing. It is carried out by saline or with heparinized saline with lidocaine saline solutions. So we can give flush with normal saline or heparinized solutions or lidocaine saline solutions. Okay, because sometimes the stone is not a likely stone but a clot which is become calcified. That means if you give heparinized solution, sometimes it washed away. And dissolution, most effective agents like MTBE and other solutions include cholate infusion and monooctanoline, sometimes given. I haven't seen this procedure, but it's written in the book. Yes, you can say during the exam, but I think you better skip it. I think, because your teacher can ask you more about MTBE or cholate infusion, or why. Then you will get puzzled. Okay, so percutaneous stone extraction by T-tube tract, a 4 to 6 week period of maturation of the T-tube tract is required. Removal of stone by Dormia basket. Okay, that is ERCP T-tube extraction and ERCP, because you can give you will push a Dormia basket through the T-tube and grab the stone. That's a procedure. And endoscopic sphincterotomy or stone extractions, if above measure failed, then the T-tube is not found in situ and accidentally removed, then after removal of the T-tube you will see there is a stone. That's why the ERCP is the only options. And papillotomy, if the retained stone is detected after the removal of T-tube, what will be the treatment option? Then what will be? If the stone is less than 3 millimeter, then no symptom, then watchful waiting. If the stone is large and symptomatic and above measures and failed, then endoscopic sphincterotomy, that means ERCP, papillotomy or sphincterotomy, then stone extraction, first line treatment, and surgery. If that is failed, then surgery, open or laparoscopic choledocholithotomy. Percutaneous transhepatic route may be used for, which is the rarest options. Okay. Now what is recurrent bile stone? When you will say that patient has got recurrent, it is not left out, but it is formed after operation. How can you know that it is a recurrent stone? Because already your stone is gone, your gallbladder is gone, the stone which is produced, it will be extracted, but patient again came with stone symptoms. So how can you know that it's a recurrent stone or not? If ductal calculi presenting 2 years or more after an operation are generally regarded as recurrent bile stone. It's a question my teacher asked me this question in the exam. That's why I put it on that lecture. So the stone is primary variety. So that means it is not coming from gallbladder. It's happened or formed in the CBD. Now, what are the treatment options of recurrent bile stone in that case? So, management of the patient with recurrent ductal calculi depends on their age and general condition. The options are endoscopic sphincterotomy and stone extraction, surgery, open or laparoscopic bile duct exploration. Others in the patient with multiple ductal calculi and grossly dilated more than 2 cm or papillary stenosis. In that case, choledochoduodenostomy, that means biliary bypass, choledochohepaticojejunostomy, choledocho or hepaticojejunostomy, which is gold standard sometimes as a biliary bypass, and then transduodenal sphincteroplasty, because I think it's problematic, because there is a chances of reflux of the food materials in that case, transduodenal, and in that case pancreatitis can be happen. So it's a risk. So it is not, it is absolute, I think, not practice nowadays. Now, what is the role of paraoperative cholangiography and its technique? During operations, you seemed that my patient, my explorations and flashing is done. Should I stop or should I reverse the operation, or going to stop it, or going for closure or not? So you have to decide during operation. That's why you will go for paraoperative cholangiogram. So during the open or laparoscopic cholecystectomy, a catheter can be placed in the cystic duct and contrast injected directly into the bile tree, and a single X-ray plate or image transfer can be used to obtain and review the image intraoperatively. The technique defines the anatomy in the abnormality like stricture and is used mainly to exclude the presence of stone within the bile duct. Now, why serum alkaline phosphatase is raised in the obstructive jaundice? Secretion of alkaline phosphatase is increased in biliary cholestasis. During obstructive jaundice, biliary cholangiocytes increase the uptake of alkaline phosphatase. So, alkaline phosphatase is raised in obstructive jaundice. Other side secretion like bones, placenta, intestine, kidney, and the source of alkaline phosphatase is differentiated by checking isoenzyme. So, bones, placenta, and intestine, kidney. So, alkaline phosphatase can be formed from these organs. So, I already mentioned that alkaline phosphatase increases the biliary cholestasis, and in case of obstructive jaundice, this is formed from the biliary cholangiocytes. Okay.